giving mic to Dr. Yasir Mehmoon, the moderator of that session, I would like to invite Dr. Raja Taha Yasin for the recitation of Holy Quran. Thank you.
Assalamu alaikum. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. ليس البر أن تولوا وجوهكم قبل المشرق والمغرب ولكن البر من آمن بالله واليوم الآخر والملائكة والنبيين وآتى المال على حبه ذوي القربى واليتامى والمساكين وابن السبيل والسائلين وفي الرقاب وأقام الصلاة وآتى الزكاة والموفون بعهدهم إذا عاهدوا والصابرين في البأساء والضراء وحين البأس أولئك الذين صدقوا وأولئك هم المتقون. صدق الله العلي العظيم.
Hello, hi, assalamu alaikum. I am Dr. Yasir Mehmood, working as a senior registrar of gastroenterology in Jinnah Hospital, Lahore. Here I am as a moderator of first session, and I would like to thank the organizing committee and President PSH to give me a fantastic opportunity to host and to moderate this magnificent event. I would also like to say thanks to all the presenters and to all the jury and chairpersons who have arrived there throughout the country despite their hectic schedules. And I I would also like to say thanks and welcome to all the participants who are here in this hall and also connected through Zoom and Facebook. Without further delay, I would like to call all my respectable jury on the stage. First of all, I would like to introduce Professor Dr. Shahid Sarwar. Sir, please come and join the stage. Professor Dr. Shahid Sarwar is a professor of medicine and gastroenterology in Allama Iqbal Medical College, Lahore. And he is among pioneers of gastroenterology in the town. And he has written down more than 50 publications under his hand. He has keen interest in paper publications and research orientations. And after his joining in as a gastroenterologist and professor of medicine in Jinnah Hospital, the department has flourished a lot. My second respectable jury is Dr. Shafqat Rasool. He is also associate professor of gastroenterology in Lahore General Hospital. And the department of Sir Shafqat Rasool is so much renowned in organizing such activities, especially in advanced GI endoscopy, and he is prominently taking part in all these activities. My third respectable jury member is Dr. Zishan Ali from Karachi. He is associate professor of Jinnah Sindh Medical University, and he is also senior vice president of PSH. He has also written down more than 50 publications, and he has a keen interest in research, and he is also in hepatitis elimination program. So all of the jury has been completed. Now I would just tell about briefly the terms and condition. Everyone know we will have 6 presenters with 6 presentations of their publications, and they have 5 minutes with 2 minutes after each presentation from question and answer session from audience and even from jury. I would like to request my first presenter, Dr. Raja Taha Yassin. He is MRCP and FCPS gastroenterology and senior lecturer in SIUT, and he has numerous of publications. I will request him to present his paper.
Assalamu alaikum. So I'm Dr. Taha from SIUT, working as a consultant gastroenterologist and hepatologist. And so first presentation of mine today is that of the role of Manl Model in predicting post-test HCC recurrence. For this presentation, I have no disclosures to mention. So to introduce, as we all know that it is the 6th most common cause of the cancer worldwide, and also unfortunately the 3rd leading cause of the death. So unfortunately, most of the cases presenting to us in OPD at a really advanced stage, and we are left with nothing apart from the palliative options. So, or loco-regional therapy. So, TACE or transarterial chemoembolization is the best therapeutic option in this case, if the portal vein is not involved. So, our aim was to identify the non-invasive predictive factors and to build a model using these predictors suggestive of post-TACE HCC recurrence. So, it was a retrospective study with a prospective follow-up, and all the patients of either gender and age between 18 to 65 years and undergoing TACE from January 2010 to December 2018 were enrolled in the study. However, those patients who had early HCC and an undergoing resection, or those patients with advanced HCC having portal vein thrombosis, metastatic HCC, patients with poor ECOG status or advanced liver disease, that is a high CTB class, were excluded from the study. So for the data analysis, we used the SPACES software, and as you all guys know, that the continuous variables, we use the pseudonymous t-test to analyze that, to compare them, and for the categorical variables, we use the chi-square test. And those variables who were significant on the univariate analysis, basically they underwent the multivariate logistic regression analysis to identify the non-invasive predictors of HCC recurrence in these post-TACE recurrence in HCC patients. So using those predictors, we proposed a model, and then we obtained the area under the operating curve, and the diagnostic accuracy was also obtained for that model. So now going towards the results, we, as it was a retrospective data, so after excluding all apart from all the other patients, like who were having the missing data or having the advanced class, we were left with 323 patients. So apart from, for that, most of them were males, and most common cause of the chronic liver disease in those patients were hepatitis C. So most of the patients were bearing a single tumor, and post-test recurrence was seen in most of the patients. And most of the patients had the timing of the recurrence was at approximately 12 months or more. So on the univariate analysis, it was the male gender, the age less than 50 years, increased neutrophil count, decreased lymphocyte count, tumor size greater than 5 centimeters, serum albumin less than 2.8, and serum alpha fetoprotein greater than 300. And there were other factors as well, which were significant on the univariate analysis. But these were the factors which were not only significant on the univariate analysis, they were also significant on the multivariate logistic regression analysis. So we basically categorized the variable, and we gave them, allocated them a number. Like male gender was given 3 numbers, age less than 50 years was given 1, neutrophil count of greater than 60% was given 1, decreased lymphocyte count was given the number of 2, and serum albumin less than 2.8, the score for it was 4, and tumor size greater than 5 centimeters had the score of 2. Basically, it was based on the odds ratio or the hazard ratio. So the higher the hazard ratio, the higher the number was given. So after combining these variables, we proposed a model which is called as a Manl model. So area under the receiver operating curve for this model was quite high, with a diagnostic accuracy of 93.8%. And the sub-analysis of this model showed that the recurrence at 3 months, 6 months, 1 year, and 2 years, this model was highly predictive of showing the HCC recurrence in these patients, and those patients undergoing TACE. So tumor recurrence was directly proportional to our model or score. So we compared this model with the other scores, and we like other markers or other scores which were available already. The research has been published on those markers. So what we saw was that our model stood out. Yeah. So to conclude, so it had an excellent diagnostic accuracy in predicting post-test recurrence, and we need further studies on multi-centered based to validate this model. Thank you.
No, it's okay. Thank you, Dr. Raja Taha. It was a wonderful talk. Next paper presentation Bisari ki hai. So I will again invite him to talk on the role of past F model in prediction of advanced liver fibrosis. Dr. Raja Taha Yasin again.
Question answer? Okay. So again, this is my second study, and it is the role of the past F model in predicting advanced liver fibrosis in patients with autoimmune hepatitis. So as we all know that autoimmune hepatitis, if left untreated, it can lead to liver fibrosis, cirrhosis, and it can cause increased morbidity and mortality in this population. So why we need to identify the fibrosis early? Because we can aggressively treat that patient and need to improve the outcome in those patients. As we all know, liver biopsy is the gold standard for diagnosing and staging the liver fibrosis. However, it is invasive, and it is associated with potential complications, like patients are worried of bleeding and the other complications. So there is a need of any non-invasive method to predict advanced liver fibrosis in autoimmune hepatitis. So we evaluate this past F model in predicting advanced liver fibrosis in patients with autoimmune hepatitis, and we established an optimal cutoff for this clinical application. So it was a retrospective study again, and we enrolled all those patients of either gender having features of liver biopsy on autoimmune hepatitis, and from January 2016 to December 2023. And those patients who were having concomitant liver diseases or those having missing data were excluded from the study. And we assessed the liver biopsy on the histopathology by using the Metaware scoring system. So for the data analysis, we used the SPSS software. And the variables which were significant on the univariate analysis, we performed the multivariate analysis. And then using that, we proposed again a model for which we obtained the area under the curve. And the diagnostic accuracy of that model was obtained. So a total of 360 patients were included in the study. Out of them, 200 were females. Most of them were females. And the autoimmune serology was positive in 308 patients. The serology observed in autoimmune hepatitis, most commonly the patients were having ANA 1:160 positive. ASMA was positive in 102 patients. In our population, we never found anti-LKM to be positive. We have already excluded those patients with concomitant like PBC, PSC, and other diseases, right? So on fibrosis, fibrosis on liver biopsy, most of the patients had mild fibrosis, while 140 patients out of 360 patients had severe fibrosis and cirrhosis. On univariate analysis, it was the female gender, raised ANA 1:160, ASMA positive, seronegativity, raised IgG levels, higher age, decreased TLC platelet count, decreased albumin levels, increased INR, increased bilirubin, and increased ALT and AST. These were the factors which were significant. In multivariate, we had, again, a lot of significant predictors, but we decided those who were having a very good odds ratio, we included them in our model. So as you can see, and we also scored them on the basis of their odds ratio, like female gender, and then total bilirubin, seronegativity, albumin, and the platelet count, right? So using this, so it was a pass-test score. So area under the curve was quite good, 0.85, and the diagnostic accuracy was 84.72%. And when we compared it with the other models like APRI and FIB4, in our population, our model stood out. With the other were having area under the curve approximately 0.79, diagnostic accuracy of 79 to 80%. So to conclude, this model might be effective in predicting advanced fibrosis in patients with autoimmune hepatitis, and so we can potentially treat on the basis of this model. However, we need further studies to validate this model. Thank you.
Thank you, Dr. Raja Taha. It was a wonderful talk. I would request the jury or even from the hall to ask any question about these two papers, these two publications, especially for Manl model and second for FAST-P. You may ask any question. Ji, sir.
So the title of this study is, this scoring will be predicting the hepatocellular carcinoma recurrence post-TACE. So when you subject a patient to TACE, there will be set of patients that will be having complete response, but many of the patients will be having partial response. A response will be graded accordingly. So did you take the patients only with a complete response, or the other patient too? Because if you included all other two, then how will you say this is recurrence? This is not recurrence.
So that is why, sir, we did the retrospective study, and we only included those patients who were initially completely responded, on which the 3-month CT scan post-TACE or 6-month CT scan post-TACE did not show any recurrence.
So of these 300 patients, more than 300 patients, how many patients did you have?
Sorry? No, after excluding everything, we had 360 patients.
And of these
323
360 patients that you subjected to TACE, how many patients did have the complete response?
All these patients were those who were having complete response. Okay. Then only we included, yeah.
Okay.
Now, I have one question.
Second question, Professor Shah.
Patients who are subjected to TACE, they generally belong to BCLC-B stage.
Yes,
that's
sir.
a huge group, considering number of tumors, considering size of the tumor. So have you done a subgroup analysis just to come up with that for which size or which number of tumors this score is more accurate in predicting? Because it's a too heterogeneous group. And such a huge group?
So, sir, yes, sir. We group actually, I have mentioned in the model that tumor size greater than 5 centimeters, and those who are having multiple tumors. However, on multivariate analysis, those having multiple tumors were not significantly associated, like for post-test recurrence. But tumor size greater than 5 centimeter was highly associated with post-test recurrence, sir.
Yes, sir. From audience, any question from audience, from respectable jury?
First of all, very nice talk. Can you hear me? Yes, so I've got a question about your second talk.
Yeah.
You very rightly said that liver biopsy is a gold standard for diagnosis of autoimmune hepatitis, right? At the end of your talk, you said that we need further studies to validate that could actually use this model for predicting the fibrosis autoimmune hepatitis. Are you aware of any studies already published that validates the use of this model in liver fibrosis? Number one. And secondly, can it be integrated? Don't you think if it can integrate it with other clinical markers for assessing the same fibrosis in such patients?
Yes, sir. So basically, in autoimmune hepatitis, we predicted this model, and this model can be compared with the other models, sir. And yes, we can involve those other clinical markers, and I have compared those clinical markers. Like I have compared it with APRI, FIF4. There are other markers like NLR, GPR. So, but they were non-specific when it comes to autoimmune hepatitis. So, because autoimmune hepatitis itself can cause the derangement in some of the enzymes if there is overlap or so. We want a model which can also predict the advanced fibrosis in overlap as well. So in that case, we might be including those. Yeah.
But what about already published studies? I just asked you.
Yes.
Have you done a literature search about already published studies
yes.
which validates the use of this model?
Okay, so basically in this model, there are no studies which have validated this model because we haven't published yet this model. So we need to validate this model.
Let me clarify, probably you're not getting the question. This is a new model which they are actually proposing. It has never been studied. They are proposing that other people should study this model. I have got a question, in fact a comment regarding your data on autoimmune hepatitis, because 300 plus patients with male predominance, that to contrary to that what we believe that autoimmune hepatitis generally presents more in females.
मैं एक चीज के बाद इसमें उर्दू में जवाब दूंगा. SIT में काम करने का कुछ ना कुछ तो benefit होता है ना. Sir, actually it was a retrospective data, so we included whatever we had. So yeah, and we excluded not only those patients. We also saw that in dialysis patients there was autoimmune hepatitis. We excluded those patients. We excluded those patients who were having hepatitis B, C, anything else. So like data both. Sir. Thank you.
Thanks for such a nice talk. Without further delay, I would request my next presenter, Mr. Mohammad Sohail. He is from PKLI. He is Registrar Gastroenterology there in PKLI. He will talk on combined kidney liver transplant in patient with type 2 primary hyperexoluria.
Assalamu alaikum. I'm Dr. Mohammad Sohail, working as Registrar in Gastroenterology and Transplant Hepatology Unit at PKLI. Today I am going to present a rare case report of a sequential kidney liver transplant in a patient with type 2 primary hyperexoluria. Before proceeding to my case report, I will go through the background of the disease. Primary hyperexoluria is a rare inborn error of glycolate metabolism characterized by the overproduction which is deposited as calcium oxalate and various organs, primarily affecting the kidneys. There are three types of this disease. Type 1, which is the most common one, due to mutation of AGXT gene, which is liver specific. Type 2, which is due to the mutation of GRHPR gene, and type 3, which is the least common due to mutation of HOGA1 gene. All these gene defects results in the increased level of glycolate, which is converted to oxalate by the lactate dehydrogenase enzyme. Now coming to the clinical manifestation of this disease, it usually affects the kidneys, results in kidney stones, which can present with gross hematuria, renal colic, urinary tract infections, and it can present with urinary obstruction. Usually these patients progresses to end-stage renal disease, which is more common in type 1. About half of patients of type 1 disease progresses to end-stage renal disease before adulthood. And they can present with systemic oxalosis, which is a multi-organ involvement when plasma oxalate level exceeds 30 micromole per liter. When they involve the multi-organ system, it can deposit in the bone marrow, causing pancytopenia with extramedullary hematopoiesis. It can involve the peripheral blood circulation, decreasing the blood supply to the peripheral vasculature, causing gangrene. It can involve the retina, causing decreased visual acuity. It can involve the bone metaphysis, resulting in the bone deformity and making the bones prone to fractures. It can involve the cardiac myocardium, resulting in cardiac conduction defects. Now coming to the management of this disorder, lifestyle and dietary measures include increased water intake in around 2 to 3 liters per day, change dieting by limiting salt and sugar, eating less animal protein, adding calcium-rich foods to meal can help reduce oxalate levels. And regarding medical management, pyridoxine and lumasiran and nidosaran have some role in decreasing the hepatic oxalate level and type 1 disease. However, their role in type 2 is not clear. Now coming to the management of end-stage kidney disease in these patients, combined liver kidney transplant has been the mainstay of treatment in type 1 disease. However, the utility and effectiveness of this approach in type 2 remains uncertain because of the extrahepatic manifestation and extrahepatic activity of the enzyme in type 2. Now coming to my case, a 29-year-old male presented to PKLI for the assessment of renal transplant due to recurrent nephrolithiasis. During the pre-transplant workup, genetic testing revealed the diagnosis of type 2 primary hyperoxaluria. Following extensive multidisciplinary team discussion, a decision was made to pursue sequential liver kidney transplantation. The base of this multidisciplinary discussion was some case reports having good results of combined liver kidney transplant compared to the isolated kidney transplantation. The liver transplantation, after thorough pre-transplant evaluation, he was operated on 2nd March 2023. The intraoperative and post-operative recovery was uneventful. The donor was his cousin with the same blood group. The GWR of the patient was 0.80 and right lobe graft without MHP was taken. He was discharged on 10th post-operative day as per normal protocol. He had regular follow-up and transplant OPD with no immediate complications. He was commenced on tacrolimus and delta-cortical post-transplant. The liver function test remained stable throughout the post-operative course. As you can see from this slide, during the follow-up, the LFTs were normal. Now coming to the kidney transplant, he was operated for kidney transplant on 21st June after initial pre-transplant evaluation. The donor was his father-in-law, 62 years old. The post-operative recovery was uneventful again. He was discharged on post-operative day as per protocol. After 2 months of transplant, he developed deranged creatinine. However, the workup revealed graft hydronephrosis, for which anti-grade stenting done, which was removed as per protocol after 4 weeks. 2 months ago, he was again placed degestant for the ureteric stricture, which was removed 2 days back after confirming urethral patency to anti-grade study. Currently, he is taking 1.5 mg BID and mycophenolic acid 360 mg BID. Up to the best of my knowledge, this is the fourth case in the literature of a combined kidney and liver transplant in type 2 hyperoxaluria, and the first case of living donor combined liver kidney transplant. Thank you.
Thank you, sir. Now question and answer from jury. No? Anything from audience? Should I proceed for next presenter? So my next presenter is Mr. Shamim Nazir, and he will talk on characterizing NAFLD in tertiary care hospital, a cross-sectional study. Mr. Shamim Nazir is PGR in Ziauddin Medical College.
Assalamu alaikum. I'm Dr. Shamim Nazir, GI resident at Ziauddin Hospital. So I'm going to present a cross-sectional study that is characterizing a NAFLD in the lean individual in a tertiary care hospital. Next. So as all you know, the NAFLD is one of the most prevalent disease, and globally, which is estimated to be 25 to 38% between 2016 to 2019. And it's a leading cause of transplantation in the United States, which can lead to steatosis, which can leads to NASH and HCC. So it is already, everybody knows that obesity is primarily linked to the NAFLD. However, in the recent time, the non-obese patients having NAFLD is gaining recognition, and previously it was initially identified in the Asian population, but it is continuously increasing. However, no data, accurate data available in Pakistan regarding lean NAFLD. So as you know that the introduction of the new nomenclature, which introduced new terms like MAFLD, MESLD, SLD, and MASH, replacement of the NASH. So the objectives of the study was to characterize a lean patient, to compare effectiveness of the criteria of MESLD and MAFLD, and just to compare the lean NAFLD patient of Asian criteria, which is 22 BMI, and Western criteria, that is 25 BMI. So we included 111 patients. We included a case of fatty liver disease, either diagnosed on ultrasound or fibroscan. Secondary causes of hepatic steatosis like Wilson disease, autoimmune hepatitis, and excessive alcoholic consumptions were excluded. So we categorized patient into MESLD and MAFLD group, and those who fulfilled the criteria of MAFLD and MESLD were grouped as MESLD and MAFLD, and those who could not qualify for MAFLD criteria was grouped as MESLD alone. And also we compared the Asian criteria of BMI of lean patients with the Western criteria of 25 BMI of lean patient. So this is the MAFLD criteria that all we know, and this is the MESLD criteria. We applied both criteria, and we took the anthropometrics laboratory parameters, and also did the non-invasive parameters of hepatic fibrosis. So these are the statistical analysis we did. So these were the result. The majority of the patients were male, and we did in the BMI of Asian group, we included 43 patients were included, and 68 in the BMI of Western criteria. The prevalence of diabetes were 18, and 59 patients had elevated LT, and 75 elevated cholesterol, and OMIR of 2 was in the 72 patients. So the 92 patients, they fulfilled the criteria of MESLD, MAFLD, and 18 patients could not qualify for the MAFLD criteria and categorized as MESLD alone. We also So in the methyl group, we found out the elevated cholesterol, low HDL, OMA-IR, and 3 or more cardiometabolic risk factors were statistically significant. And when we compared the Asian BMI criteria with the Western criteria, we did not find any significance, statistically significant in the fibrosis of the patients. So the disease is predominance